Thanks everyone for joining us, and welcome to our Lunch and Learn session, which is a collaboration between the North Eastern Yorkshire and the North West Genomic Medicine Service. Our presentation today is on genomic red flags and pregnancy. Next slide, Wahida, please. So just some housekeeping for the meeting. This is being recorded within Microsoft Teams. So those that you are attending online, we'd love to see your faces. So feel free to have your cameras on, but please have your microphones on mute. As you can hear, we have some background noise at the moment that we're trying to overcome. If you've got any questions, please add this to the meeting chat and we'll be reviewing that. We've got some fabulous people behind the scenes supporting us today, and they'll be able to feed any questions or conversation to us at the end of the presentation. So thanks for joining us, and we would like to make a start. So unfortunately, Wahida is the facilitator, but she has problems with the microphone today. My name is Denise Barnes. I'm the lead midwife for Genomics in the North Eastern Yorkshire Genomic Medicine Service, and I'm pleased to be presenting today with Vicky Arthur, a lovely colleague from the genetic counselling world over in the North West in Manchester Centre for Genomic Medicine. Okay, next slide, Wahida, thank you. So the aims of our session today are that hopefully by the end of this you will be more familiar with the term genomic red flags and how to recognise them. You'll be able to be aware of how to use the already collected information during the booking appointment and use that as a foundation to ongoing risk assessment antenatally and postnatally to explore genomic red flags, and also to increase awareness of who, when and how to refer to the clinical and prenatal genetic services. In pregnancy, genomics, or the study of the genome, is providing more opportunity now to inform personalised care planning. It's helping to increase our understanding of fetal and pregnancy-related conditions and can increase the chance of a diagnosis now where we previously couldn't provide one. By identifying these genomic risks early in pregnancy, we can use the information to help guide the management of the pregnancy, including influencing the best place of birth for mum and or baby. It really helps to enhance the reproductive conversations and decisions with predictive and preventative medicine, and looking at how we can predict and prevent conditions in future pregnancies. And it also helps to highlight the need for the emotional and psychological support for parents when making decisions around genomics, often dealing with uncertainty and risk or chance, and also the limits of the testing. So it really provides a great opportunity for the role of the midwife and enhancing that role as we become more aware of the impact of genomics in pregnancy. We now have a working definition of genomic red flags in pregnancy. We're suggesting that they are indicators in a person's or family, sorry, my screen's just been disrupted with the chat, medical history that suggests an increased chance of a genetic condition, and they also act as a prompt for further exploration, whether that be testing, referral or just a further conversation, and they don't always require a referral to the clinical genetic services. So we now have in our chat a poll that we'd like you to complete. It's 3 very short questions, and we're looking at seeing how familiar you are with the term genomic red flags currently. We like to see how confident you feel in recognising potential genomic red flags, and also if you do identify a genomic red flag, how confident are you about the next steps? So there's 4 very simple answers, and we'll hopefully be able to see live in the poll in the chat function how familiar people are and how confident people are. So please feel free to use the chat function. It might not work for everybody. I think sometimes the chat function in Teams is sometimes a bit selective, so apologies if you're not able to respond, but really appreciate you taking the chance just to interact with this initial poll. So we can start to see that how familiar people are with the term genomic red flags. They are somewhat familiar. Some have heard of it but not sure what it means, and some are not familiar at all. The majority seem to be somewhat familiar. And then how confident do you feel in recognising potential genomic red flags? We're seeing that the majority of people are not confident, and that's what we expect, and that's exactly why we're doing this session today. So hopefully we'll see a change in that as the session progresses. And if you identify a possible genomic red flag, how confident are you? So we're seeing that the majority of people are fairly confident or not very confident. So I think we've got a bit, hopefully we'll give you some more information as the session goes on to help improve on that. Okay, Wahida, can we go on to the next slide, please? Thank you. That's just go back a step. That's great. Thank you. Okay, so the antenatal booking appointment is a unique opportunity in healthcare as it helps to capture information about the health of a family around the period of pregnancy. And it's a huge risk assessment, and we use it to create the personalised pregnancy management plan. And it also provides the basis for the ongoing risk assessment throughout pregnancy and into that postnatal period. It helps identify if the mums need care pathways in the maternal medicine area or the fetal medicine pathways, or both. And it also helps to risk assess the chance of developing pregnancy-related conditions such as preeclampsia. What it currently doesn't lend itself to very well is the specifics of genomics. If you could click onto the next part, Wahida, thank you. As a broad level, I've looked at some of the maternity records used in the North Eastern Yorkshire. We have a wide variety of maternity records, and that's tends to be one of the issues, is it's very difficult to sort of get a collaboration on this. But the high level overview seems to focus firstly on the personal history. So that's normally the pregnancy profile of the pregnant woman, her LMP, her EDD, any preconception information like folic acid and fertility treatments. And then it also has quite a comprehensive history in their medical profile. So it helps to capture existing conditions like diabetes, exposure to any medication. And this tends to be where the genetics or the genomics information is captured, like inherited conditions, congenital anomalies. But it captures it and doesn't always guide what to do with that information once you've obtained it. One of the limits is the huge amount of information that's captured that may not be completely relevant now when we're looking at moving towards the more personalised and predictive healthcare planning. And that's the national narrative for the NHS. So there's a huge amount on the social profile, relevant stuff for healthcare promotion, such as smoking, alcohol and drug use. We obviously need to be very mindful of safeguarding concerns, but some of the areas like education history, we need to perhaps consider, is it time to review the booking appointment and make sure the information is actually relevant as per the gestation of the booking. If you just click on to the next one. The other thing we sometimes overlook during pregnancy is the other half of the baby's genome, and that originates from the father of the baby. And his history is just as relevant, but can be a little bit more challenging to obtain. And we also have a bit of a fear in maternity of sharing their details with others. We have a strongly embedded information governance training, and I think that sometimes influences our decision around sharing details of other family members. In the records that we reviewed as part of this presentation planning, capturing the relationship of the father of the baby to the woman. So that means whether they're related outside of that relationship or related by blood, or the degree of consanguinity, that's easily identified. But for some maternity records, it moves that into the confidential mode or the confidential information. It doesn't appear to have been a decision supported by the parents. It seems to happen automatically and removes that from the general risk assessment, so makes it harder to use that as part of the background information. It also could enhance the stigma that's attached to this, this information. We also need to consider the father of the baby, his previous children from previous relationships. There's a significant focus on social care involvement, but we really need to make sure we're considering any congenital anomalies or significant health conditions in the father of the baby's other children. And then we also have the family history, so that brings both of the parents together and provides a comprehensive list of conditions, but again, doesn't really guide on what to do about that. Next slide, please. So what we've done is we've tried to create a familiar way to enhance the booking appointment, and we've utilised an S-bar. And I think most people are familiar in maternity with using an S-bar because it standardises the way we summarise a relevant history, helps to provide a significant handover and update the care provision. So I've used that same analogy to show how the information that we get through the booking appointment can support the regular genomic risk assessment during pregnancy and personalised planning of care. So the situation, I feel, is actually the genomic red flag. So if you have parents that have either an unexpected scan finding, although these care pathways tend to be quite well defined within local trusts, the ones that are a bit more challenging to understand are the genomic red flags where you have either a family history of a suspected or a known genetic condition, and that might be a previous child or actually the parents with a known genetic condition or a suspected condition in that family. We do need to know the details of that condition and those family members that are affected, and Vicky will describe that in a bit more detail in her presentation. We also need to be very mindful that the situation could be that you've got a recurrent pregnancy loss or a family that's just experienced a stillbirth with an unknown cause, so not related to infection or a placental abruption. That situation is your genomic red flag. And then we need to add to it the background. And this is the information that you've already got through the booking appointment. So consanguinity on its own isn't a genomic red flag and doesn't require referral to clinical genetic services, but it does help to provide a bit more information and weight to that genomic red flag to help guide the next plan of care. Areas around the background as well include parental age. And I think sometimes we're aware of this when we're looking at screening for trisomies. We know the chance of a mum having a baby with Down syndrome increases as her age increases. Do we discuss that with a mum during the booking appointment and actually allow her to make an informed decision with that background information? And also the same happens for the father of the baby. As his age increases, the quality of the sperm decreases, and that can lead to an increased chance in a rare single gene disorders or congenital anomalies. Also, the ethnicity is significant because some ethnic groups have a higher prevalence of certain conditions. Thanks, Wahida. And then we have the assessment of the current pregnancy. So have they accepted antenatal screening? And it is an opt-in test where we work out the chance of baby having Downs, Edwards or Patau syndrome. But if they've opted out of screening, then we don't have the chance of their trisomy quantified. And then if you're looking at later on in the pregnancy, if you've identified a genomic red flag earlier in the pregnancy and their family, don't want to do anything about it at that current stage, as the pregnancy progresses, the information might evolve. So you might have an ultrasound scan finding with growth restriction, which may link back to that initial genomic red flag. And the most important conversations during your assessment is actually what matters to the parents. When do they want more information, or do they actually want any more information? Because some parents will want information during the pregnancy, some would not want anything until after the baby's born, and some families just don't want their genomic history revealing. And so the recommendations of the midwife, we can't know all the answers as to what conditions require referral to the clinical genetic service, but we do need to know how to provide tailored support and information to parents. That might mean linking in with your multidisciplinary team, your genetics team, your obstetric team, sometimes the pathologist from previous test results, and they may require a referral to clinical genetics, or you might want to seek advice and guidance. And the clinical genetic services, as Vicky will describe, will have an advice and guidance service within their provision, but it does vary as per local pathways. In the North Eastern Yorkshire, we created something called the GAP Enquiry, which stands for Genetics Advice in Pregnancy, and this really helps to empower midwives to seek advice if they have a gap in their knowledge and look to know what to do with that family and what they can offer in regards to genomic investigations. And then we have created, as part of some transformation project work in the North Eastern Yorkshire, some flashcards. So these are quick reference guides to help you decide what are genomic red flags in pregnancy, how to think genomics, and who to refer to if you need further advice. These are available on the North Eastern Yorkshire website. I'm now going to hand over to Vicky as the prenatal genetic counsellor for Manchester Centre for Genomic Medicine. She's going to talk to you about their service.
Thank you so much, Denise. So I just wanted to start off by doing a few definitions about kind of what is a clinical genetic service. Just want to make sure that everyone's on the same page about that, and also what is a genetic counsellor, which is the role I'm in. But I do have a background working as a midwife, so I understand, how difficult it can be from the midwifery side to perform these risk assessments as part of a busy booking appointment. So clinical genetic service is a specialised healthcare service, normally hospital-based, that will provide assessment, diagnosis, management and counselling for individuals who either have a genetic condition in their family or have concerns themselves that they may have a genetic condition. And normally, as part of that process, we can help to identify inherited genetic disorders and chromosome anomalies and the risk of passing these conditions on to future offspring. And as part of that, we can also offer genetic testing and help to interpret genetic testing results, which can be complicated at times. We also can provide guidance on prevention, treatment and reproductive options. Here in Manchester, and I'm going to say this with a caveat because I appreciate this is a national talk, everyone will have a different genetic service in their area, and every genetic service might work slightly differently. But here in Manchester, we have different teams that cover prenatal genetics, and then we also split into other categories, if you like. So a team for developmental disorders, a team for cancer genetics, a team for cardiac genetics, ophthalmology, neurology, renal and immunology, and many more. So there's lots of different sections for genetics. A genetic counsellor's role is a healthcare professional who's had additional training in both genetics and counselling, and they can explain complex genetic information in an understandable way to our families. They can assess family history and genetic risks, and they support patients emotionally while they make informed decisions about their testing, treatment and family planning options. We try and act as a bridge between patients, their families and other healthcare professionals, including doctors that might be involved in their care. Interestingly, just as a bit of a background, genetic counsellors will come from a range of different backgrounds. So there'll be people like myself that have maybe come from a nursing and midwifery clinical background, and then there'll be other individuals who have come from maybe more a genomic background or a laboratory background. Next slide, please. So as it's a national talk, I would really encourage you to become familiar with your local genetic service in your area. So obviously we've got the Genomic Medicine Service Alliances, which cover the 7 different alliances across the UK. These were sort of created to oversee and coordinate the embedding of genomics into routine healthcare across England. So you can see the map on the left-hand side shows the different GMSs and the areas which they cover. But what you're particularly interested in from a clinical point of view is which clinical genetic service covers your local area. And then the map on the right-hand side, which there is a link to at the bottom, will tell you for your area which clinical genetic service covers your hospital, and I find that really useful. And it also has their contact information on there as well. It may not be in your hospital, it may be in a tertiary hospital that's further away, but every hospital should have a genetic service that covers their area. Also, you want to become familiar with who it is that you're referring to in your local genetic service. So some people will have a specific prenatal genetics team like we do in Manchester who focus on kind of pregnancy management, and it may be them that you work with more frequently. Other places may not have that, and prenatal referrals may just be shared among many different team members. Even if they do have 2 separate teams, in most places these teams work closely together or maybe overlap. And as Denise has already mentioned, what I would really encourage you to do, if you don't already know, is find out if there's an advice and guidance route in your local area, in your local genetic service. And what we mean by that is, yes, of course, you can send an official referral. However, often that takes quite a lot of paperwork. It requires quite a lot of information to be filled in. And it may be that you don't even know whether this family need a referral or not. So is there a route? Is there someone that you can email, or is there a way of sending, a shorter referral if you just want to know, is this something that you see in your service or not? That's something that we're currently working on setting up here in Manchester. And then again, I would encourage you all off the back of this talk, if you're inspired to learn more about your local services, to have a look at the local referral guidelines. What I would love to be able to do today is show you a slide that tells you exactly what we can and can't see in genetics. But as I've already mentioned, here in Manchester, we may see certain things that other centres don't see, and vice versa. So there isn't a sort of universal guide of what you can and can't refer to genetics. And I would encourage you to speak to your local genetic service to see if they've got referral guidelines that they can share with you. And just some examples of this, so you can understand the nuances. So we're really fortunate here in Manchester to have the Sickle Cell and Thalassemia Centre, and also a team of specialist haematology midwives. And that means we don't accept referrals in pregnancies for hemoglobinopathies or hematological conditions, because they're seen by those other specialist services. However, in your local area, if you don't have those specialist provisions, it may be that those conditions are seen within your genetic service. So I wouldn't want to tell you not to refer those conditions in case that is something that is seen in your local clinical genetic service. We also really wanted to make it clear that although there are red flags that we've mentioned that we want you to look at, a red flag alone, like for example consanguinity, doesn't mean refer to genetics. It may be something that you want to investigate more, or it may be that that's something that combined with other red flags make you refer to genetics. But if we get referrals that are just for a couple being consanguineous, there's not a lot that we can offer a family like that. However, if they're consanguineous and there's a family history of a genetic condition, that is clearly a family that we would be keen to see. Across the UK, we're in different stages of mainstreaming genetic testing. And what we mean by this is, rather than doing the genetic testing in the genetics department, we're encouraging clinicians like midwives and obstetricians to take on some of the genetic testing themselves as part of their routine practice. So, for example, there's a test that we can offer during a pregnancy if we detect anomalies called an R21, which is where we can sequence the entire exome of a fetus. And here in Manchester, we've managed to mainstream that so that our FMU can now do the consenting for that. However, in other areas, that may not have been mainstreamed, and it may be that they need to be seen in your clinical genetics service. Equally, in Manchester, we do a lot of CF testing by the midwives or the GP, but in other services, they may be happy to accept CF referrals. So this is why I can't give you a definitive list of what you can and can't refer. And that's why it's so important to have these advice and guidance pathways and to develop good co-working relationships with your local genetic services so you know what they do and don't accept. I can tell you what we definitely want to see, though. We definitely want to see families where there's a history of a known genetic condition, such as Huntington's, muscular dystrophy, polycystic kidney disease. The list is endless, but if it's a genetic condition, we're keen to see it. Obviously, if we think there's a genetic condition in this pregnancy based on abnormal scan findings, normally after they've been seen by FMU, again, we're happy to see at that point. And equally, if we've seen abnormal genetic results in this pregnancy. So obviously, your screening results for trisomies are normally dealt with by the screening midwives, but what I'm talking about here is kind of more weird and wonderful microarray findings, R21 results, and so on. Never be concerned about referring too early. We are happy to see people, we'd rather see people earlier than too late. And obviously, if we see someone too late, sometimes testing options are no longer available to them because of how advanced they are in a pregnancy. So please never think, oh, this woman's only 4 weeks, she's not had a dating scan yet, what's the point in referring her? We would rather receive these referrals early than, like I say, missed opportunities occurring. Next slide, please. So how do we refer to genetics? So most centres will have a local referral form, and obviously we're keen for people to try and fill that in as much as possible, although I appreciate some of the information might be difficult to obtain. Most referral forms will include obviously your identifiers for the patient and partner, reason for referral, and the relevant family history. If we find out that there is, someone in the family with a genetic condition, say, dad has Huntington's disease, we would be keen, if possible, to know the name and date of birth of the person that's affected. I know that can be hard to obtain, but if possible, that would be really useful. Obviously, if it's a family where some relatives live abroad, it's good to know, are the relatives overseas or in the UK? Do they live in the same area that you're based? Are they living or deceased? If it's about test results in this pregnancy, obviously it's really helpful to include scan results and testing results. We have to confirm that patients have consented for referral to genetics, and obviously we want to know if families are consanguineous, and if they are consanguineous, it's really helpful to know to what degree they're consanguineous. So are they first cousins? Sometimes we get people ticking yes, they're consanguineous, but what they mean is there's consanguinity in the family, but the couple who are pregnant aren't consanguineous. So it's good to kind of differentiate where that is in the family and if it's the couple that are actually expecting. And also, it's really helpful to know what is the family hoping for. So have we just referred them to this because you've noticed these red flags on the assessment and you feel like you have to do something with that? Or is it because the family are really keen and they want to access prenatal testing, for example? So that if we have that information, it's really great to include because it can help us to sort of know where to pitch our conversation with them. And then obviously, if you do have scan reports, prior genetic testing results, or if there is a family history anywhere, if that can be attached, that would be amazing. I know we don't always have those. And when you're kind of contacting your local genetic service, it's really great to know, is there a pathway that's different for your urgent genetic referrals? So for us, any pregnant person's referral is classed as urgent, aside from our routine work where the waiting list might be 6 months, 9 months, a year. We want to see urgent referrals, normally within a week or so of them being referred to us. So just make sure that you're referring in a way to your local department that highlights that it's an urgent pregnancy referral. Just a bit of an overview as to what happens when you actually refer someone to genetics. So again, this is the Manchester pathway, but here they are triaged by a principal or consultant genetic counsellor or a clinical consultant geneticist. At the moment, we don't have a proper advice and guidance route, so a third of our referrals are actually returned to the referrer with advice and guidance, and that's why we're quite keen to set up a separate pathway for that. If it's deemed low risk and there's nothing that we can offer in a pregnancy, that's generally when we can just write to the family and tell them that and reassure them, so there's no actionable outcomes in that pregnancy. If a referral is accepted and needs to be seen in an appointment, that will be passed on to either a specialist registrar or a genetic counsellor, and they will make contact and offer an appointment. Sometimes we get referrals where there's very limited or vague information about the family history. So, maybe they've had a cousin who lives abroad who maybe had a genetic condition, but no one's really sure. There's no confirmation of the diagnosis. Often in those situations, it's very difficult for us to be able to offer anything because we haven't got anything concrete to go on. And we can't even do a proper risk assessment for that pregnancy based on vague information. So sometimes we are left with kind of not a lot that we can offer. Next slide, please. Just wanted to include a couple of examples from referrals that we've had recently here in Manchester. So I guess we've had cases where people haven't been referred to genetics because it seemed like it was a really distant relative that had the genetic condition. But just because a family member is a distant relative, it doesn't automatically mean it's low risk. So for example, we know that in X-linked conditions where only men would be symptomatic, if there's lots of female relatives linking your patient and this distant relative, they may be completely asymptomatic, but they could be carriers of the genetic condition, and that could mean that our patient that we're seeing now still has a risk that we need to investigate. So don't just assume because they're distant that there's no risk to this pregnancy. So just because a condition is genetic doesn't mean that we would necessarily see them in genetics. So in an example of this is alpha-1 antitrypsin. It is a genetic condition. It is passed on, it is an inherited condition. But I think about 1 in 10 people are carriers of alpha-1 antitrypsin. So it's not something that we usually see in genetics unless there's been someone in the family with a really severe presentation. As I've already mentioned, it's really good to know kind of what the family's expectations are. Are they really wanting urgent pregnancy management, or is it something that they're just more kind of vaguely interested in because it's been brought up as part of their pregnancy risk assessment? And again, as I've already sort of alluded to, when we get very vague histories, it's very difficult to kind of give an accurate recurrence risk and to quantify or offer testing in this pregnancy. Next slide, please. I guess some take-home messages from today that we would be really keen that you sort of reflected on would be that genomic red flags can appear in multiple different places as part of your assessment of a family. So it may be in the family history, but it may also come about in screening results or scans. And I guess the little caveat to that is just because we identify a red flag, it doesn't automatically mean refer on to genetics. It may just be something that you want to ask more questions about, or it may be that when you see it combined with other red flags, that then prompts you to make your referral. Early risk assessment allows for us to offer timely testing and support, and I hope the kind of main message that we're taking away is that we really hope that you get to know people in your local genetic service and build relationships with them to help these kind of co-working relationships moving forward. Obviously, if there's any doubt about whether to refer a family, it's always better to ask, even if that means sending in a referral and that getting returned to you if it's not appropriate for some reason. And that's why we're kind of really focusing in on building these advice and guidance pathways. Thank you. I think we're going to go back to another poll at this point. So this is the same questions that you asked at the beginning, but we're hoping that you maybe feel a little bit more familiar with some of these terms around genomic red flags and how to action these. We'd be really grateful if you could answer the questions that you were asked at the beginning again for us. I can see people are responding. I can't see the results. Hopefully that's more of a positive increase in understanding, and we can have a look at the results after today. We go on to the next slide, please. We do have a link here, a QR code for you to fill in some feedback for the talk today and whether it's been helpful or not. And obviously your input into this will directly influence kind of how we manage future lunch and learn sessions. So if you do, sorry, I know we're asking a lot of poll and then a survey, but if you can fill that in, we'd be really grateful.
I was going to say, shall I step in? Because obviously we might still have the issue with Wahida's microphone. So obviously Vicky shared with you the session survey. If you do take a moment just to scan that on your phone, it's really much appreciated, because as Vicky said, it will inform future sessions in this national series. Next slide, please, Wahida. And basically a blatant plug for the next in the sessions, which is Genomics in Newborn Screening, the Generation Study, and that's being held by our colleagues in the South on October the 13th. So again, if you wish to sign up, please scan that QR code now. But all these links will be available in the Lunch and Learn Wrap newsletter, which will accompany a link to a recording of the session today. I wanted to say as well, Denise and Vicky, we do have a couple of questions in the Q&A. So if I'll read those out. I think the first one was during your presentation, Denise. So do you offer screening in genetics in pregnancy if Lynch syndrome is confirmed for one or more parent, or is it only offered as a prenatal screening, if at all?
I think that's more a question for Vicky, actually, from a clinical genetics perspective. Vicky, is that okay?
Yeah, of course. This is a tricky one. So obviously Lynch syndrome, for people that aren't familiar with it, is a cancer predisposition syndrome, and normally recognised as adult onset. So there's been sort of detailed discussions in the past about whether this can be offered as screening for in pregnancy, because obviously if it's an adult onset condition, how relevant is that for a newborn baby and a child? This is quite a nuanced area that I don't know if I'd be able to address fully today, but I would definitely encourage you to speak to your local genetics service about that one, and it's definitely worth a referral, because we can't be expecting midwives to be able to offer guidance about that, even so yeah, basically I would definitely say that would be one that you'd refer on to genetics, and the genetic counselling team can have a full discussion with that family about what their options are. I
think it also demonstrates some of the ability for the midwives to further explore that family history and that unique opportunity that we have in midwifery and maternity care to really take a deeper dive into the health of that family. So I think if you're starting to think genomics and starting to think about conditions like Lynch syndrome, it's working out what the local pathway might be for those families, and it might be that it's just not there yet, but the fact that you're asking that question is brilliant.
We do have another question as well. I think this will be for you again, Vicky. What about screening for, again, excuse pronunciation, Ehlers-Danlos syndrome, as this can have fatal cardiac implications?
So it's, again, worth referring to your local genetics service. We don't see all types of EDS because some of it is just relating to things like hypermobility that we wouldn't test for, but there are some types of EDS, like you say, that do have more serious implications, and those types we possibly would see. But again, it will depend on your local service, and again, I would encourage referral in that example.
And maybe Vicky using the opportunity to look more into the background of that family and exploring that in a bit more detail. So using something similar to the S-bar, where you actually get a bit more information before you ask the clinical genetics team for advice, because the more information you can get from that family will really help the clinical genetics team provide the right advice and guidance.
Yeah, totally agree. Like if we think about both of these cases, the EDS case and the Lynch case, it'd be really great to know when you're passing those referrals on, who is it in the family that has those conditions, what's their name and date of birth, where have they been seen, have they had genetic testing? You may not be able to get this level of detail, but these are the types of questions we really would be encouraging you to ask. And yeah, then that can be taken on and further explored by your local genetic service.
There is one final question in the chat. So, do you test if one parent carries thalassemia trait, THALESMIA trait?
Yeah, I believe so. That's normally done. It depends on the type of thalassemia again. And for us, that's done by our sickle cell and thalassemia centre. So that wouldn't be seen in our genetic service. That would be referred on. And so, yeah, I'd encourage you to look at your local policies around that. But as a general rule, normally, if we know one parent is a carrier and it's a common condition, especially within that ethnic group, we would normally think about offering testing.
That's great. As I say, I'm just checking if there's any more questions. Just bear with me. Oh, yeah, we do. Okay. Might be a primitive question. Apologies for ignorance. Why is whole exome sequencing used in pregnant women whilst whole genome used in neonates?
That's a great question. That is kind of beyond my scope of knowledge. That's a kind of national genomic test directory decision. But I do know that they're both very good tests. And if you've already had a normal whole exome sequence, the pickup rate from them performing a whole genome sequence obviously isn't a significant pickup. So often a whole exome sequence is sufficient. And what we mean by that is the exome is looking at the coding parts of our DNA code. So the exons are the genes that actually code for a protein, whereas the genome is absolutely everything. So that includes the intronic areas between genes that were previously sort of thought of as junk DNA, whereas now we know that they actually hold quite a few important functions in terms of gene expression. So you get if you're trying to find the answer for a condition, often it is in the exome, because that is the part that is directly sequencing for genes or instructions in our body. But I guess if you've had a normal exome, there is the question of, would we find something else in a genome? Could it be in one of these intronic sequences? But that is much less likely to pick up.
I think part of that was when it first was introduced, Vicky, it was down to the turnaround times, and actually prenatally you don't have as much time as you do after the baby's born for the families to be able to make decisions, because sometimes this can influence the management of the pregnancy. So I think as quickly as genomics is evolving, it's likely that this will change in the future. So it's really worth keeping up to date with genomics information and using the test directory to help guide some of the information that you're providing to families, and actually being aware of the limitations of the testing that we're offering, because there's no such thing that will tell you that the baby's genome is normal. And we're now into the world of looking at newborn babies and whole genome sequencing as part of the generation study. But again, that's not telling us that their genome is normal, because there's no such thing. So it's really exciting. We love being part of this world, Vicky, don't we? It's just trying to keep up to date with everything that's changing so quickly. So it's great. That's a great question.
And we have another question put into the chat. Testing need if multiple early losses. What's the threshold for referring, e.g. once negative cardiolipin screen?
I would encourage you, Dr. Jones, to have a look at the genomic test directory, because that includes all our eligibility criteria for different testing. And if you look at the code R297, I think it is, I can put it in the chat once I confirm it, that outlines the testing criteria for early pregnancy losses. And I believe that this is a criteria that's under review at the moment. So you may look at it today and it may say certain criteria, but I believe that might be changing over the next couple of months. So I would definitely encourage you to keep an eye on that.
There we go. I'm just having a final check to see if we have any other questions in the chat. No, we don't at this moment in time. So if Denise and Vicky, if you're happy, I think we're able to bring the webinar to a close. As I say, just huge thanks to everybody that's been able to join today. As I say, there will be a copy of the recording along with a newsletter that will include a lot of the signposting that's been discussed today. And thank you again, everybody.